Okay, why don't we get started then? I think people are still joining us, but we'll get started now so that we have plenty of time for all of your questions today. I'm Leah Binder. I am president and CEO of the Leapfrog Group, and I'm very pleased to host this webinar featuring our very good friend, Tyler Jones. So Tyler, actually, I'm going to introduce him first and foremost as a fellow of a program at Leapfrog called the Bruce Bradley Fellowship. It's an elite fellowship for promising mid-career professionals in human resources and healthcare benefits who are the kind of people who have made it possible for Leapfrog to be so successful in driving improvements in our healthcare system and in supporting employers, most importantly, in managing their health benefits in a way that ensures that their employees are getting the safest, highest value care. Tyler has done some very, I think, very important work understanding how data can be used to inform and to strategize excellence in health benefits. And we were very excited to hear his presentation when he first gave it as part of that fellowship. And we wanted to make sure we could share it with all of you. So Tyler also has a day job in addition to his fellowship with us. He is a senior associate consultant with Connor Strong and Buckalow. And he took this year-long fellowship and he's done some very good work, as I said, in looking at hospital data, both claims data and Leapfrog data, which is different. And I think he'll talk to you a little bit about that. And then what it is able to tell us about the kind of care that your employees may be getting, and then what to do about that. So I think Tyler has some really great insights from this really good work. And also, I think one of the things that excites me the most about it is that it's transformational work. We have not a lot of tools sometimes for health benefits professionals to say, here's what you can take. This is reality. This is actual facts about the care your employees are getting that you can then translate into something that will help you in improving their care. It's very rare that we have that kind of data. That's really been over the past 20 years of really fighting to try to get that kind of data. But we finally do have at least some of the data that we want. And what's exciting, I think, is that Tyler has been able to embrace those resources and really take us to a new level in understanding how we can use them. So, little housekeeping on today's webinar. If you have a question, please put it in the chat, which is on the bottom of your screen. And then we will have a Q&A session at the end, but put your question in whenever you think of it. In some cases, we may just interject a little bit with Tyler if it's right on the point that he's talking about and try to get an answer right there. But for the most part, we're going to try to do it at the end. But there will be time, plenty of time for it. And we encourage you to ask the questions. I will have lots of my own as well. We have a toolkit that we're providing to all of you. And so at the end of the webinar, you can get a copy of the slides and you can get the toolkit and you can get a recording of the slides and send the recording off to your colleagues who you think might be interested. There'll be also contact information for Tyler directly and contact information for Leapfrog as well if you have follow-up questions or would like more resources. So I think that's it for the housekeeping. But mostly, let me introduce our good friend and colleague who's done such a great job on the fellowship, Tyler Jones.
Thank you so much for that introduction, Leah. First and foremost, thanks to all of you for taking the time out of your days to attend this webinar. I think in Leah's opening remarks, there was a lot of references to data, and that really was the name of the game. That was the angle in which I wanted to attack the fellowship, specifically the project. And what I set to do was see how it was that we could make a relationship between the Leapfrog data and the claims data that I spend so much time analyzing on a day-to-day basis from my broker and consultant seat that I sit in here at Connor Strong and Buckalow. So without further ado, let's jump right into the presentation. And what I want to do to level set the discussion is really make a case of why it is that you should care. And you see that question posed, why should I care? In this circumstance, I could be really any constituent to healthcare. That could be health insurers, a health plan sponsor, HR teams, you name it, anyone that has a stake in the delivery of healthcare and the consumption of healthcare. Patient safety and health is the top priority. I say it is the top priority. It doesn't always feel that way, but it absolutely should be. And I think that where we could perhaps end the conversation is with this first data point, the fact that patient risk of death increases by 92% within poor quality hospitals. So you see the infographic in the top right-hand side of your screen. That corresponds with the Leapfrog safety grades that they publish on an annual basis. A to B, we see a 35% approximate increase in the risk of patient deaths. B to C, 87.7%. And you see how it progresses up to a 92% more likelihood or increased likelihood in death at poor quality hospitals. And what we're defining as a poor quality hospital in this instance is those facilities that are graded a D or an F according to the Leapfrog safety grade. Consider the fact that 25% of consumers will be harmed during a healthcare encounter. That, it speaks for itself. You have four people that you are sitting at a table with. One of those individuals is statistically likely to encounter an instance of harm during their own healthcare encounter. We know that these instances of, poor healthcare, poor healthcare delivery, poor quality, poor safety in the delivery of healthcare is quantifiable. Thankfully, our friends at the Leapfrog Group have created tools to make that very real for us in the form of the calculator that they have produced. And we understand that, say, for example, 16 avoidable deaths in a health plan population of 50,000 enrolled members. That is a real data point that I was able to extract from the dollars and lives calculator that, again, the Leapfrog Group has produced. A very easy to use tool. You could go in, you can enter some specific statistics relative to your own health plan, your own population that you represent, and it's going to be able to quantify for you just how many avoidable deaths would appear in that population. Furthermore, one of my favorite statistics from, but what I had picked up from the Leapfrog Fellowship is the fact that about $40,000 is the increased cost per patient per post-surgical complication. So again, consider that $40,000 more that any given stakeholder, that might be a health insurance company, a health plan, a self-funded plan, might be paying for instances of post-surgical complications. That comes from JAMA, that particular data point. Consider the fact, though, that that was back in 2013 that they had produced that data point. Of course, you have to consider the fact that healthcare trend is increasing at a rate of anywhere from 6 to 8% year over year. That same 39,000 in 2013 is anywhere from $70 to $75,000 in 2025. Also consider the fact that that was based on a study of healthcare consumed in the southern region of the United States. So if you're someone that is like myself in the northeastern part of the country, that number is likely much higher, as we know that just generally speaking, the cost of healthcare can be more pricey here in the northeastern part of the United States. Estimates show that inpatient surgical complications range from 3 to 17% on average. Now, again, as Leah had alluded to when we opened up, what we wanted to do is make this a little bit more real. So the perspective that I was coming from was, let's not just take these assumptions, these industry accepted data points, let's instead tie them to real life employers, real life claims data. So we understand that for a 60,000 life employer health plan, that particular plan in 2023 had 4,000 inpatient surgeries. Of those 4,000 surgeries, 400 of them resulted in a readmission. So right in between that range of 3 to 17%, about 10% of the admits in whole. If you were to extrapolate, again, that industry general number of approximately $40,000 extra per those 400 readmissions, you could see that that quantifies to a very, very large cost and additional spend that that health plan might have been paying for those readmissions. However, we have the real data. We were able to see that in real life, this resulted in $1.2 million more that this health plan paid for complications. And the reason this is important is because we have the data, we have the Leapfrog safety grades, we understand the risk that is present at lower quality and unsafe hospitals. I say that because this is avoidable risk. That $1.2 million is avoidable spend that could have been redirected elsewhere to improve the health of the employee health plan or just to improve the business as a whole. We know that length of stays are greater at poorer quality hospitals, and all of these different data points that we could go on and on reiterating and trying to hammer home the fact that it's a problem if people are consuming healthcare at unsafe facilities. And finally, the point that I close out with is what I hope to have reiterated in this first slide is that it's avoidable and it is identifiable. If the costs and the lives of these health plan consumers isn't enough to convince you of the fact that this is certainly something that you should be paying attention to for a number of different reasons, perhaps consider even the fact from a benchmarking perspective that, for example, according to the Business Group on Health, in 2025, centers of excellence tend to be the one strategy in which health plans are adopting to really control costs. That is the thing that large employers are reporting most when it comes to what are they doing to control what we know to be a growing cost year over year. And we know that centers of excellence are heavily informed by quality, safety, things of that nature. So it seems like a no-brainer that perhaps centers of excellence even should be considering quality data, specifically Leapfrog data, and likewise health plan constituents as they develop strategies to help calm these costs and just make sure that their employees not only have access to care, but the care that they are accessing is helpful to them and it's not ultimately harmful in the end. I've added this slide in more so just to provide some context as it pertains to the hospital safety grade. The hospital safety grade is a weighted metric. So the A, the B, the C, the D, the F, presumably, is all a result of a handful of different measures that fall into one of these three pillars: a structural measure, an outcome measure, or a process measure. The hospital safety grade in particular is weighted 50% structural and process measures and another 50% by your outcomes measures. And again, I just wanted to provide some back end context because when we speak to how the safety grade is actually developed and why any given facility is receiving a safety grade, it is because of the measures that fall into one of these three buckets that are ultimately informing that grade that is assigned at the end. So one thing I would encourage you to do when these slides are distributed, you can access this information at your own leisure and just refer to this example, say at the bottom, just to help acquaint yourself with how exactly the structure measures relate to outcomes, relate to processes, so on and so forth.
Tyler, we have a question that I think is relevant to the research that you just showed. So maybe we could answer
Sure.
right now so that while
Yeah.
we're thinking about your research,
Mhm.
what safety grades are directly correlated with these metrics? I think the ones, at least that I know of, that are directly correlated are the first one that you cited, the study that Johns Hopkins did around the safety grades and differences among hospitals. But I think the others are not scaled against the safety grades.
Correct. Yeah. I think that the safety grade is something that is developed by Leapfrog, whereas, for example, the 39,000 more per patient that was developed elsewhere outside of the realm of Leapfrog, that was a JAMA statistic that was produced when it comes to, the benchmarking that comes from the Business Group on Health. So I say that just to make it clear that the safety grade specific information developed by Leapfrog, that risk of death increasing by 92%, that is a Leapfrog derived statistic. But as for the others, those would all correspond with the sites that you see referred to here at the bottom. Of
Thank you.
course. One of the important things that I wanted to do with my project was to help level set how exactly Leapfrog data can be used across different stakeholders. What you see here is health plans, employers, researchers, transparency vendors, self-insured entities, just some examples of how each of these different stakeholders can utilize Leapfrog information, not just the safety grade, but also considering the survey that is produced as well. So I'll pull a couple of examples. Health plans can use these to identify centers of excellence, as I had alluded to on the first slide. They can display data for health plan members on a provider finder website so that when a member is searching for a particular provider, they have it right there in front of them. How is this provider doing from a safety perspective? Self-insured entities can use this to inform the construction of narrow networks, absolutely helping with plan design and things of that nature. I think about from a researcher's perspective, it is absolutely how I look to hone in on this data throughout the duration of last year, leveraging the information for studies to further legitimize findings, things of that nature. Transparency vendors absolutely can help use this to better inform the value equation, corresponding, or rather integrating the safety component of that into their calculations and the information that they ultimately produce. And of course, employers, executing tiering, engaging in direct contracting, making sure that they beware engaging in a direct contract, perhaps with an employer or rather a healthcare facility that isn't demonstrating, consistent quality and safe healthcare. Now, that is more so a resource that I encourage you guys to use, or rather, this slide is a resource that I encourage you to use when thinking about how it is that different people can utilize this information. But of course, the perspective that I come from is bias. So for that reason, you see consultants sitting here at the center of the screen. Again, that is the perspective that I come from. And I place them at the center of the screen because if you think about the role, or rather even the definition of a broker, it truly is a middleman, engaging or rather helping to facilitate agreements, contracts, things of that nature. So when we think about the definition of a broker, I think that it makes sense that we would have them at the center or the core of all of these different stakeholders. But I kind of want to abandon that idea of just acting from a broker perspective and really acting in a consultative fashion. And I feel that that is the responsibility that we have nowadays is not to just simply broker deals, but to truly leverage the expertise that we can bring to the table. And being that we sit at this crossroads for in between all of these different health plan stakeholders, it really is just a true unique opportunity in my perspective to bring together employers with health plans, with researchers, help share ideas, and make sure that ultimately the healthcare consumer is benefiting most from the strategies that we are putting in place.
Tyler, if I could just add one thing to your comments, this is a really excellent slide. It's actually really comprehensive and I think captured some really important strategies that are out there in the larger world of health benefits and really trying to drive change in healthcare.
Mhm.
I would add that one thing that employers do with Leapfrog data and other kinds of data that you're going to talk about is inform their employees. They want their employees to make good choices and good decision making. And as your chart is showing, there's a lot of others out there to help them do it, like the transparency vendors, the health plans, and to your point, fundamentally, they're consultants who can connect all of those players together for the benefit of those employees. So just to remind everyone the importance of just really engaging the public in making those decisions.
Absolutely. Absolutely. So before really getting into the core of what this presentation speaks to, I want to help distinguish the Leapfrog Hospital Survey from the safety grade. I think really the overall summary, the primary takeaway is that the hospital safety grade is more fit for granular analyses, going into specific condition categories, very particular procedures, things of that nature, relative to the Leapfrog safety grade, which is more fit for a high level analysis that really just looks at the rate of care consumed at unsafe providers. The safety grade is, the A's, the B's, the C, the D's that are assigned to all these different facilities. And keep in mind that it is facility-based, inpatient specifically claims for the most part. It's exclusively focused on safety, so other measures, the measures of which that the hospital survey goes into, are not considered. And as I had stated, the hospital receives a single letter grade that is ultimately what is produced with the Leapfrog safety grade, whereas the Leapfrog hospital survey covers a variety of different measures across quality, safety, resource use, and things of that nature. And then a hospital's progress on each and every one of those measures is displayed in the form of, 4 different criteria that speak to how well they are performing for any given measure. So again, just keep in mind the fact that if you are looking to utilize the survey, that is going to allow you to dig a little bit deeper into the claims data or whatever data that you're trying to tie it to. And the safety grade rather is going to allow you to just get a high level indication at what is the rate of unsafe care being consumed in any given population. Now what I would label as the fun stuff, really the core of what the presentation and the projects sit to explore. And that being tying the Leapfrog data to claims data. Now I know Leah at the beginning of the presentation had mentioned there's a distinction between claims data and Leapfrog data. The Leapfrog data is, of course, produced by Leapfrog. It is distributed in the form of the safety grade or the hospital survey, which is looking at all of these different measures that speak to quality, how healthcare is being consumed, and what is the rate of adverse events that are associated with that healthcare consumption, and really is just speaking to, how safe is the healthcare that is being consumed and delivered at any given facility. I really think that that is the name of the game. When I think of Leapfrog, I think of safety, period. When you think about claims data, that really is specific to the payer side of things associated with, whether it be a fully insured health plan or a self-funded health plan. There is, of course, other funding mechanisms, but ultimately it is the way in which people are consuming the healthcare, how it is being paid for, and so on and so forth. So again, Leapfrog data specific to safety, claims data is how populations are actually utilizing healthcare. When I sit to tie together Leapfrog data to claims information, there are a couple of particular components that I think are very important to understand. So first and foremost, the data source in which you extract this information, particularly the claims information. If you're a self-funded health plan, you might have access to a data warehouse. So I listed a couple of examples of data warehouses that we are familiar with and we utilize here at Connor Strong and Buckaloo on behalf of our self-funded health plans. If you are a fully insured health plan, you might be thinking, and rightfully so, that it could be challenging to access your health plan information, specifically your claims data. Typically, fully insured plans and your carriers are holding on to that data. You might get limited reporting, and in that instance, it really is a conversation with that fully insured plan, or rather that health insurance company, to see what exactly you have access to. What is the scope of data that you may be able to tap into? A benefit of being a self-funded plan is that you have access to that data at your full discretion. So, from my perspective, being that I work primarily with larger self-funded employers, all of them are in data warehouses. And for that reason, we really have just about every single thing that we might want to examine at our fingertips. And that is all stored in these data warehouses. When we think about the reporting period, I think this is one of, I didn't go into the project understanding just how important it would be to understand the reporting periods. But you have to keep in mind, first and foremost, that the survey and the safety grades, the data that is being reported on varies between both of those products very drastically, specifically within the survey, for example. In one of the case studies that we're going to examine in 3 slides, we look at maternity outcomes, specifically the rate of C-sections. That measure is reported from Leapfrog on a very specific time period, that being calendar year 2023. So if you were to go through this exercise and extract claims data that spoke to calendar year 2024 and try and make that correspond with the spring 2024 safety grade, it wouldn't necessarily be, it wouldn't really be an accurate inference that you were making, because just fundamentally, the period in which you're comparing the claims data to the period in which Leapfrog was speaking to wouldn't necessarily align. So just keep that in the back of your mind, that if you were to replicate a similar exercise, it's very, very important to make sure that the data that you're reporting on, the claims data that you're extracting, aligns with the measures that you're looking to speak to, whether it be in the survey or the safety grade. To that point, I absolutely encourage the use of incurred data. That would be incurred data relative to paid, because the challenge with using paid data is that we understand that there is a lag in how claims are paid. Say on average a 3-month lag from when that service is consumed to when it is actually paid. So when we're looking at how healthcare is actually being utilized for any given time period, there's not going to be necessarily a one-to-one correlation with all of the claims that sit in one particular time period relative to when it was paid, because we understand that there's a lag in which those claims are ultimately paid at the end of the day. So for that reason, we want to look at when those claims were actually incurred and make sure that that's aligning with whatever the measure is that we're looking to compare it to across the survey or the safety grade. One of the final points is how you would actually get to the data that we're looking to get to when correlating Leapfrog data to claims data. Any of these 16 or so fields are going to give you a majority of what I would say you would want to infer from this information or from this exercise. Of course, most important is to have that provider name and the provider MPI. I say those are most important because if you think about how the Leapfrog data is produced, specifically on the back end, the output that feeds the surveys and the safety grades that we see in their nice, pretty client-facing formats. On the back end, it is a lot of raw information that is stored in things like Excel, for example. So my analysis primarily was facilitated using Excel. I was able to take claims data in an Excel format and tie that to or rather Leapfrog data, which was also in an Excel format, using a field that corresponds between each. And that field that corresponds between each is the provider MPI. Think for the safety grade, for example. The safety grade takes a look at all the providers that Leapfrog evaluates. It assigns a safety grade to each individual provider, and that provider has a corresponding NPI. When I extract claims data, I would just want to make sure, as I've outlined here in the reporting fields, that I have a provider name and a provider MPI present so that I'm able to make that correlation and tie that information together. Beyond the provider identifying name, things like service category, place of service, to give you an idea of, was it inpatient claims? Was it, what type of service was being consumed, inpatient, outpatient facility, what have you. A network tier indicator to give you an indication of, was this in-network services? Were they out of network services, or what have you? Diagnosis specific information so that you can make inferences to what type of care was being consumed, perhaps at a unsafe provider, such as cancer care, circulatory care, musculoskeletal related care, you name it. Of course, hand in hand with diagnosis information is the actual procedure that was being done at any given provider. Billing codes, I think, are particularly powerful and useful in this instance, just understanding the nature of what is ultimately reported on with Leapfrog safety grades and survey results, specifically because they're speaking to care within the facility. And in a majority of instances, CPT coding doesn't always correspond with inpatient related claims. We have to look instead at things like revenue billing codes, which help shed some light on what type of procedure was being done and what place of service, things of that nature. So in the instance that, the claim that you're attempting to tie a grade to wasn't provided in the inpatient facility setting, you're not necessarily going to be able to leverage the CPT code. Or rather, if it is in the inpatient facility setting, the revenue billing code is just going to shed more light on what was being done. And then in the form,
Question about that, Tyler?
sure.
The CPT, so CPT codes cross settings, is that what you're saying? Or is not
So
necessarily just in the inpatient setting?
CPT, I think to put it in layman terms, CPT codes don't play well with inpatient related claims.
Okay,
So if you were to extract the claim file with a service category breakdown for anything that is inpatient related, that CPT column almost in every single instance is going to say not available. Simply because when there are instances of inpatient specific claims, that CPT methodology isn't leveraged. CPT codes are better fit for, an encounter at the professional level. Maybe there was shots administered, maybe there was, just a high level office visit, things of that nature. Whereas for instances of your inpatient facility stays, the revenue billing code is more often tied to that type of claim.
so if you go in for procedure at an inpatient level, a CPT code may not be assigned, or it's how,
Correct. No, that's exactly right.
wow.
So but that's not to say that the procedure isn't, you're not able to determine what the procedure was. That procedure information is going to be available in things like the revenue billing code. That's why I kind of
I
keep
see.
going back to that example.
Well, that's
And then
interesting. It's a nuance I didn't know in years and years of doing this kind of work. So thank you.
absolutely, yep, no problem. And then finally for your numbers, things like allowed amount, paid amounts, to get an indication of how many times in which people are going to any particular provider, things like visits, patients, so on and so forth. So I just wanted to give you guys a high level indication of what type of fields you might want to include in a report to kickstart you into your analysis when making an effort to tie any one of your health plans, populations, what have you, to the Leapfrog information. My final point on this slide, and perhaps the most important, and it kind of goes hand in hand with the nuance between like the CPT code, for example, is the fact that in going through my analysis, I was looking to tie this information together and was finding that about 50% of the dollars for the analysis period that I was looking at didn't have a corresponding Leapfrog safety grade, or rather, when I would try to make a correlation, I was getting an error in any of the formulas that I was trying, and I couldn't really wrap my head around it until I really had to take a couple steps back and look at the fundamental picture at what Leapfrog speaks to, and that really is your brick and mortar facilities.
Mhm.
When I made that refreshing reminder to myself, I then looked at the service categories, the places of service for the claims that didn't have an associated Leapfrog grade in the claims file. And that would be the things that you would expect: professional level services, outpatient visits, things of that nature. So just to level set for yourself, you're going to encounter claims that you simply can't make any inferences to with the Leapfrog data. And that's simply because it's just not things that Leapfrog is grading fundamentally in the safety grade, and likewise reporting on with the survey. When you think about the share of facility related claims for any given health plan budget, for example, 50% of those costs on average are typically going to be attributed to facility specific claims. So it would make sense that that share of 50% being, related to professional outpatient related things, and therefore unable to be graded or have a corresponding connection between the Leapfrog data that I was trying to tie to originally. Before getting into our two case studies in particular, I just want to level set, what is actionable between each of the different sources of information that we have available to us. Again, that being the Leapfrog safety grade and the survey report. In the survey report, as you can see, there are a lot of different criteria that we can dig into. And within each of these different titles, we have available to us a bunch of different Leapfrog metrics that we can explore. And when I say a bunch, I truly mean a bunch. There are a lot of different things that can be examined here. Whereas taking it back to a couple slides ago, where I had alluded to the fact that the hospital safety grade was more fit for higher level analyses, that really is the name of the game when thinking about how we utilize the safety grade. So again, just a friendly reminder that when utilizing the safety grade, we're just trying to get an idea of the rate of care consumed at unsafe providers relative to the survey, which can be used for much more granular analyses. Do keep in mind that the hospital survey report pretty much buckets each of these measures into 4 different categories: limited achievement, some achievement, considerable, and achieve the standard. Ideally, achieving the standard is where you are going to want to see a majority of the providers being utilized fall into. And that will make a little bit more sense in terms of the inferences that can be made in just about 2 more slides. Into our specific case studies. So the first one was where I sit to examine just your high level utilization of unsafe providers utilizing the hospital safety grade. When we think about the makeup of the employer and my approach, first and foremost, this was an employer in the healthcare industry. They have about 50,000 members on their health plan. The source of data that I used was the data warehouse that this employer in particular leverages, keeping in mind that this is a self-funded employer. The time period that I was evaluating was calendar year 2023. And I just wanted to give an example of some of the fields that were included in the report. Didn't include any specific CPTs, ICD-10s, or anything of that nature, because again, this was just a very broad, high-level look at how care was being consumed across different providers and how that corresponded with the safety grades assigned to them. One thing in particular that was a question that I had gotten a lot when I had first given this presentation was how exactly did this go down? And all of this was facilitated utilizing Excel. You can picture 2 Excel reports that we are provided with, one of which being a claims data file, the other of which being the raw Leapfrog safety grade report that has all the providers that are graded and all of their corresponding grades with an NPI. I used a formula that I find myself using all the time. That is an index match, but you absolutely can use any formula of your choice, whether it is a VLOOKUP, a XLOOKUP, whatever formula it is of your preference that is, just most comfortable for you. I urge you to use that. But ultimately, the name of the game is making a connection between the Leapfrog raw data file and the claims data file that you might have available to you. As for the inferences that we made or the outcomes of the analysis, first and foremost, 10% of the graded claims accounted for 50% of the spend. And that's exactly what we would expect. Thinking back to the data point I gave around what share of the health plan budget that facility specific claims account for, that would be about 50%. From a volume perspective, only about 10%, because if you think about it, these are your highest costing, most intense encounters of healthcare. It's not your cheap office visits, things of that nature. It's your costly inpatient stays, which are typically driving the lion's share of costs. When we think about the share of claims assigned to lesser quality providers, or rather providers delivering unsafe care according to the safety grade, we see that 37% of claims that were graded were paid to C and D graded providers. Furthermore, of that 37%, 85% of those claims were what we call domestic. I do want to define that because keep in mind that this is a healthcare provider. And oftentimes when you see health systems, in addition to having, your standard networks that we would associate with in-network, out-of-network, things of that nature, you also have your owned healthcare system network. And more often than not, health systems are looking to bring members of their health plan back into their health system for care. The logic is, why would we pay for you to go get care at our competitor when we can keep you here within our own health system? It begs a philosophical question because, again, 85% of care, or 85% of those graded claims at C and D providers, I think the thing that comes to mind is, do you want to continue steering care to your own facility if the care isn't the safest? I'll allow you participants to answer that question for yourself. The third finding was that 1,000 inpatient admissions across 750 members were at C and D graded hospitals. So again, we see a high rate of inpatient admissions at C and D hospitals. We know that that can be problematic because those C and D hospitals are just innately more likely to cause harm for those people that are actually going and staying within their facilities. 55% higher incidence rate of readmissions at D hospitals relative to A, and 20% higher readmissions at C hospitals relative to A hospitals. Going back to that first slide, we understand that, again, at an industry literature or from a general perspective, that we see higher rates of readmissions at unsafe hospitals. But again, the name of the game was making this real and quantifiable for your clients or for whoever it is that you're really trying to hammer home the point that these things are very real for their own populations. 35% higher average admission cost at D providers relative to A providers. And that is in large part due to the fact that there are higher rates of readmissions, complications among those D providers relative to A providers, resulting in just higher costs. So again, all of these things that we can infer from the claims data simply by tying the safety grades to each of these different providers that make up any claims set. What do we do with this information, though, is the next question. The opportunity that it presents is an opportunity to redirect care to alternate providers, rather, for cancer and circulatory care. And I call out cancer and circulatory care because a large majority of care that we see within this 85% among these domestic providers was for cancer and circulatory care. So again, we have very specific conditions that we can focus on. We have an alternative in that we're redirecting care to not only alternate providers that are safer, but we can maintain domestic utilization because we were able to infer that there are 2 alternative domestic providers within a 25-minute or less drive relative to the the C hospital that we had seen so much utilization at. Furthermore, when we think about just an opportunity to improve business processes, the actual client, in this instance, the healthcare provider, can take this information and leverage it to improve the care at that C-rated hospital that we saw so much utilization going to. When we dig a little bit deeper, the Leapfrog safety grade gives very clear reasons why that a hospital was rated the grade that they received. In this particular instance, the rates of sepsis, the high rates of sepsis at this provider in particular, in combination with challenges specific to provider communication, were really what drove their C score. I think that is very powerful information because it doesn't just tell the group that, hey, you have a C-rated hospital, but you have a lot of people going here. Here are things that they're suffering from, and here are very specific things that you can help, that you can leverage to improve the delivery of healthcare. If you're focusing on strategies to improve the rates of sepsis, if you're looking at internal processes that you're using between providers on how they communicate on any given shift, those are very specific opportunities that they can take and improve not only their health plan, but their actual business as a whole.
If I could just add something to that, Tyler, the claims data is going to basically tell you the incidence of a particular problem, like an infection. But what the safety grade adds to that is answering the question, is that bad? Like if I have 100 infections in one hospital, that sounds bad, but is it worse, or is it, how bad is that? Can it be better? Should I expect it to be better? I mean, those kinds of things are very difficult for employers to grapple with if they're not clinicians. And so the safety grade says, yeah, it is. It's a D hospital. So yes, that is much worse, and you could do a lot better. Here's how A hospitals do. And so you can set your sights on improvement based on not just what you think should be the performance, but on where other hospitals are achieving better results.
Sure thing. Second case that I looked to examine was utilizing not just the safety grade, but the survey results as well. As I had mentioned earlier on in the presentation, the survey is more fit for very specific, focused, granular analyses. So what I sought to demonstrate in this second example was taking a look at just one of the measures that are reported on. In this instance, I sought to examine maternity outcomes. Specifically within maternity, the rate of C-sections and how those were reported on the survey results for any given provider relative to what they're seeing in the claims data. The employer group that we looked at, very similar demographic and makeup of the last employer group, but just a different state, a different area, a different provider altogether. Likewise, they were a self-funded health plan, so we had the ability to leverage the data within their data warehouse. And as I had mentioned earlier on, the time period we were looking at for this particular example was calendar year 2023, because that corresponds one-to-one with the measurement period that was looked at to report on the C-section rates within the the survey report that we were using. This report build was a little bit more particular because I was looking for very specific diagnosis codes, ICD-10 codes, things of that nature. So in particular, we are looking at diagnosis related groups falling into these different codes. In layman's terms, all of these essentially report incidences of C-section, whether from a diagnosis perspective, whether from a diagnosis related group perspective, or the actual CPT specific to these things. I also wanted to couple in what I'm labeling the 06 series of ICD-10 codes, because that is where we're going to identify rates of complication. And I wanted to see if there was a correlation between, complications and C-sections among any of these providers that might have had a higher rate of C-section relative to others. The methodology was 100% the same as what we had done with the safety grade, and utilizing Excel to map the results from the survey report to the claims data. What we ultimately found in this instance was that 50% of members with a C-section had the procedure performed at a provider that was reported to have either some achievement or limited achievement. So that corresponds with, I'll jump back up a few slides, some achievement and limited achievement relative to considerable in achieving the standard. The standard C-section rate, or rather the rate of C-sections to achieve the standard according to Leapfrog would be 23.6% or lower, while some achievement and limited achievement are falling in the range of about 25 to 30+%. So again, there was certainly some room to improve for any of these providers that were being categorized in the some achievement or limited achievement buckets. And we know that 50% of members, half of any individuals getting a C-section, were performed at providers that just had worse off C-section rates. Much like the outcome that we had with the analysis where we looked at safety grades, 85% of these costs were made up at domestic providers. Domestic in this instance, same exact definition as we had called out on that last slide, essentially within their owned facilities. I do want to call out that in the case study, what I looked to do was to normalize costs on a per thousand, or rather a per member per month, per employee per month basis, so that when making inferences between costs across each provider, we were adjusting for the fact that some providers were just seeing more patients. So inevitably they might have higher costs because they're seeing more volume. So in an effort to really get a true indication of how costs are stacking up against each, we have to normalize those costs across each provider. In the case study, we saw costs were actually highest at providers with considerable achievement. So we want to see considerable or meeting the standard achievement for any of these different measures. That aside, complications and harm were nearly 20% more common at providers with some or limited achievement. So putting the cost component of this aside, we know that there are just higher rates of complication, which kind of go back to the first slide when we were speaking to just how, the impact of complications, the costs associated with those, things of that nature. And we again see this data becoming very real from a very real data set. The fact that harm and complication was 20% more common at providers that had worse scores in the actual survey results. So again, we take this information, what can we do with it? So the opportunity in this instance, a lot like the first case study, was to redirect care to an alternate domestic provider for deliveries. We see that 75% of patients live within 15 minutes or closer to a better performing facility. So for that reason, it is really no problem to steer that care to a provider. And again, we are maintaining that domestic utilization, so keeping the spend and the care within the owned health system, but patients are going to safer facilities. As point A mentions, we're maintaining domestic utilization, and there's an opportunity to improve the care delivered at some of those domestic providers that are scoring worst according to the survey results. And finally, thinking, in my opinion, what is the most important criteria of this all? It's not necessarily about the costs and things of that nature. It really is about making sure that patients are receiving safe healthcare, that your own friends, family, employees are not harmed during their healthcare encounter, that it's really counterintuitive to what people are going to receive healthcare for in the first place. And then finally, an opportunity I see presented here, thinking about it from a benefits perspective, is the opportunity to modify that plan design to incent utilization of not only domestic providers, but the domestic providers that we know are performing better than others. So perhaps if you have an incentive, a financial incentive perhaps built into the plan design to steer to domestic facilities, you go even further to specify what facilities that you are looking to steer care to while you're working on improving some of the C-section rates, for example, at providers that might have been scoring not as favorably in years past. And to close out the project, the analysis, I really just want to remind you all that this is a tool, one of many tools that we can leverage, whether it be the safety grade, whether it be the survey. It's not necessarily the end all be all. So I'm not suggesting that you go into a strategy meeting this year and your primary topic is how we're going to use Leapfrog data in 2025. It is, again, just a tool that I think you can use to complement some of the strategic recommendations that you're making for clients. When I think about the areas that are most ripe for opportunity when tying Leapfrog data to claims data, I personally feel that it is in network design and how it is that you're steering care to particular providers. And then forward thinking, how is it that we can leverage this data to glean even more insights for any given health plan or population of healthcare consumers? It is exploring never events, which I know are of particular interest and passion to the Leapfrog group, utilizing whether it be ICD-10 coding, CPT coding, revenue codes. That really will take a deep dive to understand how it is that never events are appearing in claims data. Another thing that we can do is to broadly analyze the prevalence of post-surgical complications, specifically using, to start at least, the T81 series of ICD-10 codes. That T81 series is most associated with complications. So, just doing a broad analysis to see what providers have a higher rate of complications utilizing that T81 series of codes. And then finally, leveraging the Leapfrog survey report to look at more condition-specific analyses. So in my example, we had looked at maternity care, but as you saw in that outline of all the different measures that are reported on in the survey, we could explore cardiovascular care, musculoskeletal care, you name it. There are a lot of different condition-specific analyses that can be performed here. So I hope that was useful to you all. I hope I've inspired some type of ideas in how it is that perhaps you as a broker or a consultant can utilize Leapfrog data and tie it to claims data, or to level set expectations for health plans and how it is that the individuals that are helping you manage your plan can be analyzing information on your behalf and making it so that at the end of the day, your employees are put in the best position to consume care that isn't ultimately going to result in harm in the end. So thank you for listening to the presentation today. Looks like we do have about 5 or so minutes for questions, so I'm happy to answer any questions if we've received some at this point, Leah.
Yes. Thank you, Tyler. This was excellent. And I would add that this also gives employers some new tools for having important, persuasive conversations with the C-suite about the kind of investment that needs to be made to strategize the best possible health benefits and inform employees so they can make good decisions. There's a lot of very valuable information here where you can say, well, because so many of our employees are going to this C hospital for maternity care, it is costing us more, and it's not necessarily getting our employees the best care. And we can show exactly where those lives and dollars are being risked. So you can show that in the claims, and then you can verify it through Leapfrog that it can be much better. So, so thank you, Tyler. This was excellent. And we do have there's one question in the chat I'm going to bring up. I will say this probably will require a longer conversation, but let you address it. I come from an employee well-being perspective. Employer focus today is largely on well-being, not just health. Tyler, how might your project's development strategies be applied to the other domains of employee well-being beyond just employee physical health, especially the domains that lack claims type data? Before you say anything, I want to say one thing. Employee well-being, when we're talking about patient safety, we're talking about preventable issues that are the third leading cause of death in this country. So that I consider that an employee well-being perspective. That is a critical well-being situation that employers can do something about today. So let's not, we don't consider this outside the bucket of well-being. But Tyler, did you want to comment on that question?
Yeah, sure. When I think about employee well-being, it is a holistic approach first and foremost. Whereas when we're at the point in which an inpatient stay is warranted, presumably they're beyond, the preventive initial stages or initial parts of the spectrum on the well-being spectrum. I think that the name of the game when it comes to well-being is providing resources that are going to prevent ultimately the utilization of certain types of healthcare that I think are more often graded by Leapfrog. So I think that Leapfrog does a good job in providing other resources aside from the safety grade and the survey report that might speak better to what can be done from a well-being perspective. Candidly, my inclination is to say that when we're looking at this type of analysis, it is some of the more catastrophic instances that are in some of the latter stages on the spectrum of employee well-being. I keep going back to that verbiage of a spectrum because that's really how I visualize well-being, and the needs of people that fall in different categories on that well-being spectrum vary greatly. So I think that the survey and the safety grade are perhaps fit to inform the latter half of that spectrum. Whereas I think you're better off looking perhaps elsewhere to address some of the more preventive aspects of well-being and the things that span beyond just health, um, all of the different components that make up well-being aside from the physical aspect, but the mental, the financial components of it as well. If you think about from a cost perspective, all the things that we had highlighted to kick off the conversation, those costs not only are borne by the health plans, the employers that are paying for these things, or the health insurance companies, but consumers are paying for this themselves out of their own pockets. So there's a lot of different avenues in which you can look at the well-being equation. So, to address the physical, we're talking about avoiding the inpatient stays and stuff like that. But from a financial perspective, the actual fact that this is costing people a whole heck of a lot of money that they should be able to redirect elsewhere to help just kind of improve their overall well-being. So you're right, Leah, it is a loaded question. The concept of well-being is something that we spend so much time talking about because it is so multifaceted. There is no, one solution fits all. But when I think about Leapfrog and how it fits into the well-being equation, I think it's about preventing those costly inpatient stays and things of that nature that are ultimately going to potentially harm employees in the end.
Thank you, Tyler. That was very well stated. But we certainly will are glad to talk more about that. As I said, on our website, we have posted the recording of this webinar as well as a toolkit for you and contact information. You see Tyler's contact here, contact information for Leapfrog as well if you want more follow-up information on anything that's been presented today. So thank you for being with us. Thank you, Tyler, for this excellent presentation, this terrific work, very inspiring. I think there's a lot that we can do with this, and you've really, I think, taken us to a new level and being able to offer employers the kinds of tools they need to do the very best, highest value work for their employees. So anyway, thank you all for joining us, and we'll see you on our website. Thanks.
Everyone.